let's say it's either high grade or low grade and you're not doing any intravesical therapy. Maybe it's the patient has really bad lower urinary tract symptoms. They can't hold the agent. Maybe they just live really far away and it's not feasible for them. I know you and I both practice in areas where distance is an issue. We have quite
Absolutely.
rural populations. What does that conversation look like? How hard do you push them? I think that's a big challenge for us because a lot of times patients will ask, do I really need this? And I think in this space, the answer is not as straightforward as BCG for high-risk disease.
Yeah, I tend to agree with you that it can be challenging. Again, it's, leaning on patients to see what they're able and willing to do. For folks who are not wanting to do any sort of intravesical treatments, then oftentimes I keep a slightly closer eye on them during surveillance just to make sure. I always counsel people, if you have any blood in the urine, I always want to know about it right away. I should be the first phone call outside of your spouse. I think that's helpful just to kind of set some expectations of when they should call you. But for those folks, I generally don't push super hard unless it is, for low-grade disease, I don't push super hard unless it is multifocal disease. Those folks, I feel like, have some sort of abnormality within their urothelium that is, causing things to have multiple sites that pop up. Similarly, when it's recurrent disease, that's when I push people a little bit more. So if they had a, 3.5 centimeter tumor that you resected, you gave peri-op, gemcitabine, and they're like, Doc, I can't make it here. Then those folks I offer, this is what the standard of care is. This is what our guidelines recommend. But if they don't, I don't push for it too hard. If they've come back and they've had multiple recurrences and I'm on we've already gone through one agent and they have a bunch more tumors popping up, then those are the folks who I really try to encourage them to get some sustained intravesical treatments just to get that cytotoxic effect. The other thing I always have to keep in the back of my mind with these folks with recurrent disease or multifocal is just making sure you evaluate their upper tracts, make sure you get a CTU so that they don't have something that's shutting down, because when things are behaving a little bit abnormally, you just want to, dot your I's and cross your T's.
Yeah, that's a great point. Definitely an important thing to remember. So, BCG, gemcitabine, BCG obviously can be a challenge at times. I recently read a new update from Merck that they're working on the plant, so that's great.
We're 4 years into still working on the plant. Yeah. I'm any day now.
Yeah. But let's talk about some of the newer agents. Again, I think the majority of them are generally discussed in relation to high-grade disease, but I'm aware that certain populations in specific trials did include intermediate risk patients, and there are drugs that are specifically for the intermediate risk space. So, wondering if you could give me a little bit of the lay of the land, and I'd love your comments there.
Yeah, there are a couple of new ones all at varying stages of FDA consideration. I think the first thing we tend to rely on is Doce, just because it's easy for us and that's FDA-approved, easy to get, it's relatively cheap. When we start to get into some of the newer agents that are up at the FDA right now, there are things like Anktiva, so that's the IL-15 superagonist, and 803 that we're looking at. That was studied under QUILT. This group is a little bit hard to interpret kind of some of their early data, but they were FDA-approved in April of 2024 for BCG unresponsive disease. So kind of next step is looking into some of these folks who haven't had BCG. From the data, it looks like that agent is going to be most effective in folks who have high-grade disease in combination with the Anktiva plus BCG. So one struggle with a lot of these is they still rely on some form of a stable BCG supply. So I think that's been a bit of a struggle. But so I think that one's out there. I think there'll be more data coming out. I know there are a couple of different trials looking at it in the BCG naive space of high grade TA. So I think that'll be an important one to look at. Another one that's just had a new drug application submitted to the FDA that we should hear an impending decision in June is the UGN-102, which is a gel form of mitomycin. And that one is more specifically for low-grade disease, and that gel form should help it have longer contact time with the urothelium. A larger study of about 240 patients looked at that, 6 weekly installations. It's given through a catheter, so the same way that we typically give, so that makes life a little bit easier than some newfangled way of giving the agent. But 80% complete response rate at 3 months. And of those folks who responded at 12 months, 82% of those were still disease-free. So that's really promising. And that's in folks who have some untreated, small, low-grade disease. So this is an agent that looks like it maybe can do some of the job of cleaning up some of those little things that you may see when you're doing your surveillance cystoscopy. You might be able to eradicate those without having to go in and surgically remove them, which would be ideal, really.
Yeah. I mean, I think that's a great point with the UGN drug because it, we don't think about this enough, but it's actually chemoablative. And so it's obviating the need to go to the operating room, which is obviously convenient for the patient. But I think in some of our patients, like these patients can be pretty old. They can be pretty frail. I know we talk about TURBT like it's an in and out thing, but for some of these people, it is not.
Yeah, and some of these folks are on blood thinners and trying to get them off of those and get them back on for surgery. I mean, that to me is a huge win. I feel like so many people with bladder cancer are on Eliquis and Xarelto and trying to bridge them on and off, and the safety profile of doing some of that stuff. And this is a really nice option. A lot of times, because they're on those agents, it's not super easy to ablate them in clinic or fulgurate them in clinic. So if you have a drug like this, it's really a nice thing that you can offer your patients.
Yeah, I agree. And it's interesting that it is also one of the few areas where we've had dedicated trials in the intermediate risk space.
Absolutely.
So I think that either way, it adds to our understanding and our confidence to arm us with these discussions when we're in clinic, when we're talking to patients, and just have a better understanding of the disease process in general.
Yeah. And I think, too, it's, some of these newer agents, as they come online, using them sensibly, like this thing isn't going to get rid of a 5-centimeter low-grade tumor. It's just not. But for those folks who you see who have these tiny little smattering of a couple millimeter recurrences, like this is a really great, opportunity to treat somebody in that space in a much less invasive manner.
Yeah. And, again, we talk about TURBT. I think in most cases it goes really well, but sometimes there are those challenging locations, there's challenging bladders, and so it's good to have that option.